Hello everyone. In this section, I would talk about anesthetic management for emergency aortic surgery. I would discuss this with a case presentation. So I was doing my duty in emergency and I just received a call that I am about to receive a patient who is 74 years old with aortic aneurysm rupture in hemodynamic imbalance. So when I received this kind of call, so what kind of patient I just received? Patient was 74 years old, male, with ruptured aortic aneurysm, and the patient was in hemodynamic imbalance, okay. So blood pressure of the patient was 70 by 50 mm of Hg. So whenever we receive this kind of patient, we are about to receive this kind of patient, there are some important preparation we need to take. There are some important alerts, signals we have to send to the blood bank, etc. So how do we manage this kind of case? Remember, a ruptured aortic aneurysm, for this always emergency open aortic surgery has to be done. So we have to do emergency open aortic surgery. Now, I have already discussed the management of elective open aortic surgery. In this section, I would discuss the management, what is peculiar to emergency open aortic surgery. So when I receive this kind of call, before receiving the patient, before the patient is coming to me, I would start preparing along with additional staffs which I may require. So we would start our preparation. So what are the things I need to prepare? We need to prepare our monitors, the special monitors which may require. So special equipments may be required for intraarterial line insertion and pressure transducer, etc. CVP catheter insertion tray we should prepare. Then transesophageal echocardiography also we should get the access to be inserted in the patient. So all these devices which we need for monitoring the patient who is of ruptured aortic aneurysm in hemodynamic imbalance should be prepared. Then the second thing which we need to do is our vasoactive drugs. The patient may be in hypotension, tachycardia, bradycardia, sometimes hypertension, arrhythmia, whatever. So all the vasoactive drugs which requires to manage these conditions we need to prepare. And thirdly, we need to alert the blood bank. We may require a massive blood transfusion. We may require multiple blood products. So we need to alert the blood bank. If possible, we should ask while the patient is being shifted for a sample to be sent for cross-matching and blood typing. Okay. So what did I say? The first thing which we should do is start preparing the monitors which we need, which would be needed in the patient. So monitors, equipment for insertion of intraarterial catheter, central venous access, and transesophageal echocardiography prepared. So all these equipment should be prepared. Then vasoactive drugs, right? So vasoactive drugs to manage hypertension, hypotension, right? Tachycardia, bradycardia, and arrhythmia. All the drugs should be prepared. So for hypertension, we need to prepare all our vasodilators, right? We should keep the vasodilators in hand, the NTG, the esmolol, etc. For hypotension, we need to have our vasopressors and inotropes ready, phenylephrine, noradrenaline, etc. For tachycardia, we need to keep our beta blockers in hand. For brady, we need to keep anticholinergic agents. And for arrhythmia, we need to keep antiarrhythmic like amiodarone, lidocaine, etc. in hand. So all the vasoactive drug emergency tray should be prepared. So emergency tray should be separately prepared. Third, we should alert the blood bank. So preparation for transfusion, preparation for transfusion. Okay, so as I said, if possible, typing and cross matching should be done. So typing and cross matching of blood should be done. At least 10 units of PRBC and FFP should be prepared, or the similar product should be prepared. Blood bank should be alerted. Blood bank should be alerted for the massive transfusion and the requirement for it. And apart from this, we need to prepare all the equipment required for high volume transfusion, like the blood warmer and the rapid transfusers. So high volume transfusion devices, transfusion and warming devices should be prepared, right? Apart from this, the body warming devices also, we don't want the patient to go into hypothermia. Massive transfusion can lead to coagulation, the dilutional coagulopathy can lead to hypothermic coagulopathy. So we need to avoid all these things, because this patient may require a massive transfusion, right? So we have to do all the preparation for massive transfusion. Now, once my patient arrives, now immediately when the patient arrives, we need to know about the cardiac pathology of the patient, and we need to know about the emergency of the procedure being performed, and we need to know any procedure patient has undergone prior to coming for the surgery. So, first we need to assess the cardiac pathophysiology, and understand the emergency of the procedure, emergency nature of the procedure, proposed procedure, right? And also we need to know about any pre-op intervention patient has undergone, right? Any pre-operative intervention, right? Now, apart from this, from the family of the patient or the caregiver, a brief history regarding patient has to be taken. So, brief history from family or the caregiver should be taken. Now, what all things we have to ask in this history? We need to ask about any allergy of the patient. We need to ask about the allergy of the patient. We need to talk about the fasting status of the patient. We need to know about any relevant past medical and surgical history. So, relevant past medical and surgical history, right? We need to know about any previous anesthesia exposure and problem associated with it. So, problems with prior anesthesia exposure, and we need to know about recently administered drug. So, any drug patient has recently received, recently administered drugs, and recent lab report. If patients, any recent investigation reports patient relatives have, recent lab reports. And apart from this, if time permits, we need to review the patient's chart, right? All previous and the current chart, right? Regarding recently administered drug, we need to be very careful about the anticoagulants or antiplatelet drugs these patients may receive, right? They may be, this is a 74-year-old patient, may have a lot of cardiac comorbidities. He may be on a lot of anticoagulants or antiplatelet medications. So, and that has not been stopped before certain, let's say, desired time period. Patient has to be taken for emergency surgery. So, we need to reverse the effect of these anticoagulants for the safe surgery to happen. So patient emergency reversal of the medication affecting the hemostasis may be required in these patients. So if the patient is on antiplatelet drug and discontinuation has not been possible, so in this patient we can give the platelets. We administer the platelet, either one FRSS unit or 6 units of pooled platelets, right, to overcome the recently administered antiplatelet medication, right? Because in the patient, if the antiplatelet medication is effective, then unacceptable microvascular bleedings can happen. So we need to give the patient platelet concentrate, a ferritic platelet or the pooled platelet. Okay, if the patient has received anticoagulants and discontinuation has not happened, it's an emergency surgery, then we need to reverse the anticoagulation. For warfarin, if patient is on warfarin, the best would be the 4-factor prothrombin complex. We should give, rather than giving the FFP, 4-factor prothrombin complex would be most appropriate. If with 4-factor prothrombin complex, vitamin K should also be administered to the patient, right? Okay, if this is not available, then we can go for 3 factors prothrombin complex. If this is also not available, we can go for FFPs. So depending upon what is available, if 4-factor prothrombin complex concentrate is available, which is the preferred approach, we should give 1500 to 200 units IV over 10 minutes. Check the INR within 15 minutes. If the INR after completion of infusion is not less than 1.5, right, we give additional 4-factor platelet prothrombin complex concentrate, and we give vitamin K 10 milligram IV over 10 to 20 minutes. Okay, so 1500 to 2000 units over 15 minutes, wait for 10 to 15 minutes, get a prothrombin time done or INR done. INR is still more than 1.5, then we again repeat the dose. If this is not available, if 3-factor prothrombin complex concentrate is available, then we give 1500 to 2000 units over 10 minutes. Check INR after 15 minutes after completion of the infusion. If INR is not less than 1.5, same, we repeat the dose. And we give, let's say, we give the factor 7A 20 microgram per kg IV or give FFP 2 units IV by rapid infusion, right? Factor 7A may be preferred if the volume overload is concerned, and we give vitamin K 10 milligram IV over 10 to 20 minutes. Okay, so in 3 factors, we give additionally factor 7A concentrate, and we can give FFP also, right? If neither 3-factor prothrombin complex or 4-factor prothrombin complex concentrate is not available, we have to give FFP, right? Give FFP 2 units IV by rapid infusion. Check INR after 15 minutes. If still more than 1.5, give 2 additional units of IV FFP with rapid infusion. Repeat the process until INR is less than 1.5. And definitely we give vitamin K 10 milligram IV over 10 to 20 minutes. Number of time prothrombin complex is not available, right? Prothrombin complex concentrate is not available. FFP is what we have to rely on. So as I told, we give 2 units of FFPs. We get a INR done. If the INR is more than 1.5, we again give 2 FFPs. We again get the INR done. If the INR is still more than equal to 1.5, we again repeat 2 FFPs. So since number of times we have to repeat a lot of FFPs, the risk of volume overload is there. So we need to carefully weigh the volume overload and manage it, right? And definitely vitamin K we always have to give to all the patient, right? Vitamin K we will give. If the patient had a direct oral anticoagulants agent, then like that inhibits thrombin or factor 10A, they have a shorter half-life than warfarin, but they have reversal agents. We should use the specific reversal agents which we can use for these agents. So we have to reverse the antiplatelet and anticoagulants of the patient, right? Now after this, if the patient had taken fibrinolytic agent, some fibrinolytic agent was given. So we can give antifibrinolytic agent, and we can give the patient cryoprecipitate, plasma or fibrinogen concentrate, right? In addition to administrating the antifibrinolytic agents like the aminocaproic acid, right? So we can give antifibrillary agent. We can go for point of care coagulation testings by ROTEM or TEC and specifically target what exactly we have to give to the patient. Okay, so once we have reversed the anti-hemostatic drug, right, now we would induce the patient, right. Number of time we don't have time and we start the induction and do other supportive maneuver along with it. So now starting with induction. Now induction is same as the induction we do for the elective open aortic surgery with some very important pertinent differences. Now these patients may be in hemodynamic imbalance and giving anesthetic agent would further decrease their blood pressure and hemodynamics, deteriorate their hemodynamics. So once surgical preparation, prepping and draping is done, then we induce our patient so that immediately surgeon open the abdomen, reach the aorta and clamp it. Number of times the surgeon immediately open the abdomen and clamp the aorta, right? So after taking all the precaution of surgical preparation, we can induce the patient. For rapid sequence induction intubation should be practiced. Patient may be full stomach. It's an emergency surgery. And the drug used for induction should be the drug which affects the hemodynamic less, like your ketamine or etomidate or high dose of opioids. So, severe hypotension may occur with induction, right? So surgical preparation, the prepping and draping, surgical prepping and draping should be done before giving drugs, right? So as soon as abdomen is open, sometimes the aortic clamp is applied to the patient, right? Now rapid sequence induction has to be practiced. Rapid sequence induction has to be practiced, right? For this, we can use etomidate, which is a cardiostable IV anesthetic agent in 0.3 milligram per kg body weight in a titrated way, or we can use ketamine, right, which is used in shock patient. Ketamine would sympathomimetic would increase the blood pressure 1 to 2 milligram per kg body weight, or we can use high dose fentanyl, right. High dose fentanyl can be used alone or as an adjuvant in the dose 5 to 8 microgram per kg body weight. Now number of times patient may be having high sympathetic tone and may be having increased blood pressure, then in that case we should judiciously use the adjuvant. The adjuvant should be judiciously used. Okay, so we have to maintain the hemodynamics. So this is how we have to practice the induction. Now coming on maintenance of anesthesia. For maintenance of anesthesia, right, we need to let's say practice the same way what we practice for routine open aortic surgery. We can go for inhalational, we can go for TIVA, we can go for combination. So we can go for inhalational, right? We can go for inhalational. We can go for total intravenous anesthesia, or we can go for inhalational plus IV combination, right? Now, one thing I want to tell that you have to do induction number of times immediately the patient comes in the OT. So when the patient, you have done a fast reversal of the anticoagulants and fibrinolytic and you're planning for induction, definitely as soon as the patient enters, or maybe patient would be having 2 large bore IV cannula, right? CVC line may be inserted after induction. Intraarterial line should be taken as soon as possible. Maybe number of time we don't have time, we will induce first and then take the intraarterial line, right? So CVC line as soon as possible, intraarterial line as soon as possible, and number of time patient will be having extreme pain, ruptured aorta, right? the pain would radiate to back and lower abdomen, extreme pain. So analgesic should be given as soon as possible. So IV analgesic prior to induction, IV analgesic to control pain, Patient will be in extreme pain, and this all can cause hemodynamic effects. So prior to induction, these things can be practiced. Okay. Maintenance, as I said, is same as you do for any open aortic surgery. We can go for inhalational, we can go for ISO, we can go for SIVO, we can go for DES, any of these three, right? They are cardioprotective agents. TIVA, we can go for propofol plus Remi infusion in a titrated way, and we can go for combinations as well. So we can use maintenance, right? Then coming on fluid and blood management. Now it is same as we do for elective aortic surgery, right? Elective aortic open surgery, right? So it is same as elective open aortic surgery, Now here patient is in hemodynamic imbalance, massive blood loss. So massive transfusion protocol should be followed. Massive transfusion protocol should be followed, right? So for massive transfusion protocol, we need to follow in these patients 1:1:1. That is, for 1 PRBC, we give 1 FFP and we give 1 platelet concentrates, right? So fluid management, the blood management is mostly same as open aortic surgery. Okay. Hemodynamics. Now, how do you manage the hemodynamics of the patient? The systolic blood pressure of the patient should be targeted above 100 mm of Hg with the help of vasopressor if required. So systolic blood pressure should be kept above 100 mm of Hg. Now in some centers, they practice permissive hypotension. So permissive hypotension is practiced in some centers. They decrease the blood pressure to decrease the blood loss. So permissive hypotension can also be practiced, right? But there's a risk of spinal cord ischemia with permissive hypotension. So we have to see the risk benefit ratio. Now post-operative, so after completion and clamping and declamping, everything same as the open aortic surgery, what we have already discussed in the section anesthesia for open aortic surgery. Post-op management, these patients may require the ICU supports for hemodynamic and they may not immediately get extubated after the surgery. So post-op ventilation management, post-op ICU support and post-op pain management should be done in these patients. So post-operative management, we should shift the patient to ICU, the surgical ICU, then pain control should be taken care of. Pain control, as we manage the pain control in any critically ill patient. In critically ill patient, opioids is the mainstay for the pain control. So multimodal analgesia, opioids are the mainstay, and proper management of ventilation and hemodynamics. And hemodynamics should be done, right? Hemodynamics. So this is how we approach an emergency aortic rupture surgery, right? Preparation is very important, right? Proper preparation, induction, intubation, everything should be planned. Maintenance, the intra-op management of aortic clamping, cross clamping, everything is same as open aortic surgery. The only difference which we need to consider, number of times surgeon, as soon as the abdomen is open, they clamp the aorta, right? So induction, etc. should be done once the surgical preparation, prepping, dressing has been done. You cannot even wait for putting all the monitors before induction if the patient is in huge hemodynamic imbalance. You may not have that kind of time also. So this plan is according to the patient, how much time the patient gives to you, and according to the emergent nature of the surgery. Okay. So this is how we manage emergency aortic repair surgery. Thank you.